A very good morning to all here at the Ideal Village Conference, co-chaired by the distinguished Dr. Sunny Anand. Thank you, sir, for inviting us. We are extremely pleased to participate in this important humanitarian conference. My talk, which I am delivering from Amrita campus in Kerala, is titled The Critical Role of Telehealth for Rural Medical Care in the Pandemic Era, a very timely subject indeed. I will begin with disruptive challenges due to COVID, talk about the paradigm shift, smart and connected telehealth, Amrita's precision framework and health at home station, then move on to global trends, rural success stories, challenges, and end with future projections. Let me start with the news I came across that is heart wrenching. Gary Fowler, 50 plus, went to three major Detroit hospitals begging for help because he was having difficulty breathing, but was repeatedly turned away and died soon thereafter. Just hours prior to that, his father had passed away after getting the same response from the hospitals that they're completely clogged. The explosion in COVID cases has spiraled into a vicious cycle in rural areas. In villages, a meager 4 physicians and 2 ICU beds per lakh, hospital resources are choked. Added to it, there is the fear of COVID infection and travel hassles, including lockdowns. The first result, dramatically reduced availability and utilization of health services. In fact, WHO did a survey of 155 countries, and it revealed the second point. Up to 53% countries with curtailed services for hypertension, diabetes, etc. This in turn has caused a surge in previously subdued NCDs and communicable diseases. The impacted numbers in rural India is mind-boggling. 3 lakh diabetic people have missed treatment. 3 lakh babies have missed vaccinations, and the list goes on. Fourth point, such neglect makes large number of rural folk even more vulnerable to contracting COVID-19, which further feeds into the fifth point, snowballing of COVID cases. All of this has triggered a paradigm shift. First, proactive hospital-centric care to managing patients at home. Second, an ironic reversal. The doctor at home, but patients in a remote hospital. And third, the patients at home receiving care from a doctor who's also at home. So what is it that is needed to sustain this paradigm shift? I call it re-engineering medicine, and the panacea is telehealth. Actually, it began decades ago, but it stagnated to just audio-video calling for teleconsultation. So what is actually new? Telemonitoring is becoming so pervasive to all specialties. Using optical signals, telecom networks can even transmit MRI or X-ray images in a fraction of a second from remotest areas. Wearable non-invasive sensors based on infrared ultrasound signals are able to capture physiological parameters, and mobile phones with high-resolution cameras are able to take on microscopy. Moreover, the concept of teleinterventions conventionally includes e-pharmacy and teleguided procedures, but taking it even further, remotely triggered drug delivery systems and microneedle patches for vaccination. We can now glue them all in software and make them smart. Given the ever-increasing sensors that are being approved, we connect them up through body area internet and enhance them with the power of informatics and intelligence, what we call the 3 I's. The result is going from simple digital parameters, we can derive complex diagnostic biomarkers, obviating the overdependence on hospital-based investigations. Some working examples: saturation monitors can diagnose viral illnesses. Gait and speech devices can monitor ALS and Parkinson's. Wrist phone PPG devices can diagnose cardiovascular conditions. Skin patches can treat diabetic ulcers, one of the commonest reasons for long hospital stays. Suitcases with ultrasounds and digital scopes are being produced that patients can use to help doctors remotely diagnose and treat their conditions. Here at Amrita, we have architected a 5-in-1 finger clip device that captures vitals and glucose also non-invasively. From digital biomarkers to actionable insights, here is where the power of AI and machine learning comes. So let me now speak about the multi-purpose health at home station developed at Amrita. The patient, in the comfort of their home, steps into the station. With the help of wearables and an auto-mounted smartphone, vitals, audio, and images are captured, quantized into a health motif by physician assist filters, and transmitted through the gateway to the EHR cloud. Here, machine learning is applied for risk stratification and forwarded to the doctor's smartphone, who can then prioritize patients. This has been validated for acute cardiac events in rural Kerala, with surprising prediction accuracies exceeding 95%. And the system also resulted in energy savings of 90% and bandwidth savings of 98%, proving their sustainability and suitability to rural areas. Okay, telehealth to combat COVID. In a COVID scenario, how do we predict events such as sepsis well in advance to provide enough time for remote patients to be brought to the healthcare facility? This is our precision framework called RASPRO. The summarization engine first computes the most dominant trend in vitals called the COVID vitals motif. The severity engine computes disease trajectory and an advanced warning score is derived. Then a decision support system computes the home to hospital alerts. This system then transmits the alarm along with the data at the required level of detail and the network priority as shown in this table, and this is available in one of our papers. So the COVID vitals motif is personalized, the advanced warning scores are predictive, and the decision support system is preventive, hence the 3 Ps. Okay, global teletrends. Most major healthcare providers have adopted telehealth in a scalable manner to combat COVID. In the USA, top specialties are gastro, cardio, etc., and patient visits have increased from 11 to 77%, and the market size is expected to grow to 130 billion. In India, top specialties being ophthalmology and mental health, the eSanjeevani platform has completed over 4 lakh teleconsultations, and the market is expected to grow to 5.5 billion. This momentum of telehealth is driving ambitious disease prevention goals, such as the Million Hearts 2022. Next, some rural success stories and impact. 3 measures of impact in the rural scenario are accessibility via connectedness, availability via time savings, and affordability via cost savings. So the 3 A's. Success stories are pouring from around the world in many specialties, heart and head, pediatrics to geriatrics. A telestroke program in the rural belt in Alabama has achieved a sharp 6-minute time to intervention. Stanford's Cardio Click has achieved 90% success in preventive lifestyle improvements among vulnerable population in California. Cardiovascular telemedicine in rural Australia increased the indigenous patient screening from 12 to 17% and reduced reporting by 57 days. A recent project in India called Step 1 has conducted 3 lakh teleconsultations for COVID and prevented 2 lakh new cases, saving 2,000 lives and 20,000 hospital beds. Using soft electronics, Northwestern University has developed wireless neonatal skin patches for vital signs, heart sounds monitoring, etc., and optimized it for rural settings. Amrita has established a telehealth network reaching out to 101 villages. It is credited with the first telesurgery in rural India, in which a cardiologist remotely guided a local physician to do the procedure in a mobile telemedicine unit. It's also known to be first in disaster relief via deployment of a solar-powered hospital on wheels, especially for power-starved rural areas. There are also some challenges due to rural realities. Let's look at them. In order to replicate such success stories in villages, we need to address these unique challenges, such as infrastructure, particularly lower power and bandwidth in the last mile. The numbers on the right shows the mismatch between the required and the available bandwidth. And to bridge this gap, our precision framework uses motives. Health and hygiene awareness may have to be emphasized, language and digital literacy barriers, and problems such as shelter, health, language, literacy are exacerbated by the mass influx of migrant populations, especially during pandemics. Okay, some hot out of press projects. These are some out of the box, large scale experimental telehealth projects to combat COVID. Pennsylvania Health has managed to treat more than 4,000 patients through COVID Watch, an automated system, without escalating to human care. Very impressive. At Stanford, Dr. Schneider's group has achieved great results in pre-symptomatic detection of COVID through wearables to capture heart rate variability and activity levels. In a project called TempPredict by UCSF and UCSD, users wearing Aura rings are continuously monitored for vitals to detect the spread of COVID. Scripps also has an interesting project on wearable health data from Fitbit to detect outbreaks of influenza and other illnesses. For a moment, let's ponder about a poser. Sacrosanct personal touch between the physician and patient. Does telehealth have the promise to fulfill this hope? Yes, because of a revolutionary new technology that resonates with the Sanskrit word avatar. Avatars are a synthesis of an interplay between haptics, robotics, and stereoscopy in the dimension of augmented reality. Like a physician's second body, neural linked avatars can exactly emulate touch, movements, actions, and subtle skills needed for clinical exams and basic procedures at the patient via telepresence. In the doctor's own environment, a 3D holographic avatar of the patient is created. And by transcending distance, they can dissolve the physician-patient barrier and push the limits of telehealth. And I'm not talking of a wild dream, because in fact, as we speak, XPRIZE teams are fighting it out to be the first to get there. AR, VR, and avatars are great, but still missing would be compassion. The most potent healing force, like a one that is a source of irreplaceable value when placed beside zeros. So may I end my talk with an inspiring quote of Amma from a distinguished lecture she delivered at Stanford in 2014. Begin quote. Today, universities and their researchers are ranked mainly based on funding, the number of papers they publish, but along with this, we should also take into consideration how much have we been able to use their research to serve the most vulnerable strata of society, end quote. This conference fully resonates with Amma's quote. And in closing, I would like to express telecredits to Dr. Sunny Anand and Dr. Prem Nair for their valuable guidance. Thank you all for your interest, and I'll be happy to take questions.